Good evening, my dear students. So today's sorry online lecture is about rectal prolapse. I'm Dr. Prasad Paul from the Department of Surgery. So what is prolapse rectum? Prolapse rectum is the eversion of rectum through the anus. That is, it presents as the mass coming down the rectum. The rectum is coming down through the anus. That is the eversion of rectum. So there are of two types. One is a complete prolapse. That means protrusion of all the layers of the rectum, or it may be partial, whereas there is only the prolapse of the mucosa or mucosa and submucosa for about 1 to 4 centimeters. The prolapsed mucosa can be palpated between the thumb and the fingers. So it is composed only of a double layer of mucous membrane. So in infants, the causes of prolapse may be an undeveloped sacral curve or a reduced resting anal tone, whereas in children usually results following an attack of diarrhea, which in turn may lead to loss of weight, or loss of weight leading to the consequent loss of rectal pad of fat. So this can bring about the prolapse in children, or diseases like cystic fibrosis, neurological causes, or maybe even due to maldevelopment of pelvis. So how do you treat this rectal prolapse in infants and young children? First and foremost is you do a digital repositioning. Then you replace the protrusion. For that, the parents are being trained. But what if the digital reposition fails? You give submucosal injections of 5% phenol in almond oil. So what will happen? When you give this injection, it results in the aseptic inflammation of the mucous membrane, and this results in the adherence of the mucous membrane to the muscle coat, thereby preventing the prolapse. So if this doesn't work, then you have to intervene surgically. So the child is put in the jackknife position. The retrorectal space is entered after dissection, and the rectum is sutured to the sacrum. So that is the surgical intervention in infants and young children. Now about full thickness prolapse or prosidentia. This commonly occurs in women aged 50 or above, and are almost 6 times more prone than men to rectal prolapse. And in women, this full thickness prolapse may be associated with uterine prolapse also. Young males with this full thickness prolapse or prosidentia may have associated psychiatric disorders. They may also tend to take constipating medicines because of the anticholinergic effect of the psychiatric drugs. Now coming to the anatomy and pathophysiology of this rectal prolapse. So one such cause which is attributed to the development of rectal prolapse may be the diastasis of the levator ani. Secondly, it could be due to an abnormally deep pouch of Douglas or cul-de-sac. Then you may get a sigmoid colon with too much of redundancy, or a very much patulous anal sphincter which will bring the rectum down, or the attachment of the rectum to the sacrum might be lost, or it could be due to a chronic or a lifelong constipation with a component of straining. So these are the anatomical and pathophysiological factors which contribute to the development of rectal prolapse. Now we talk about neurological causes. One such is the pudendal nerve neuropathy. So a proximal bilateral pudendal neuropathy is present in incontinent prolapse patients. Pardon me for the wrong spelling. Pudendal, the spelling is Pudendal. This is responsible for the denervation atrophy of the external sphincter muscle, which has got a very important role in the continence. So pudendal nerve damage may also cause weakening of the pelvic floor and the anal sphincter. What are the causes of pudendal nerve damage? It could be a direct trauma resulting from an obstetric injury, chronic diseases like diabetes mellitus, or maybe the sacral nerve root damage resulting from neoplastic necrosis. So these are the causes of pudendal nerve damage. Now, what are the clinical features of the prolapsed rectum? The symptoms could be tenesmus, that is feeling of incomplete evacuation, sensation of tissue protruding from the anus on defecation. So initially it might get reduced spontaneously, but subsequently the mass has to be pushed back. So this may result in fecal incontinence and mucus discharge. So these are some of the clinical features. So chronically prolapsed rectal mucosa, what will happen? It might get thickened, ulcerated, and results in bleeding. So this is all a gradual presentation, but sometimes the presentation of rectal prolapse may be dramatic or acute. One such complication is an incarcerated rectum. That is, the prolapse segment getting incarcerated below the anal sphincter. In such a case, emergency operative intervention is indicated. Now coming to the differential diagnosis. The most common differential diagnosis is a prolapsed incarcerated internal or external hemorrhoids. But this can be distinguished by close inspection. So a prolapsed incarcerated internal hemorrhoids. The internal hemorrhoids may come down and gets incarcerated. So this can be distinguished by close inspection. Prolapsed piles, you can see radial invaginations showing hemorrhoidal Cushing's. So something which has prolapsed. External hemorrhoids are already there outside the rectum, but internal hemorrhoids, when get prolapse, may undergo incarceration, but they show radial invaginations at the site of hemorrhoidal cushions. So the direction of prolapsed tissue folds will be concentric in prolapsed rectum, whereas in prolapsed piles you see radial invaginations. Moreover, prolapsed piles are painful. They might be accompanied by fever or urinary retention. Not always, but whereas the rectal prolapse, unless it is incarcerated, it is easily reduced and painless. In children, one of the differential diagnosis is you may have an ileocecal intussusception. That is one differential diagnosis for this rectal prolapse. So the complete intussusception resulting in abdominal pain, distension, might be bleeding. So most importantly, the ileocecal intussusception, it might lead to abdominal pain, vomiting, distension, and especially this red currant jelly stools. So that is one differential diagnosis for rectal prolapse in children because of the bleeding. Especially when you suspect an incarcerated rectal prolapse or hemorrhoids or an intussusception. So the diagnosis is by careful history and physical examination. To exclude the colorectal cancers, colonoscopy is done. 35% of the patients might be having urinary incontinence, whereas another 15% might have vaginal wall prolapse. But sometimes, even when you take the history, the patient might be complaining of prolapse, but when you examine, it is not being detected. So what will you do? You need to confirm it by asking the patient to produce the prolapse by straining. If still elusive, you go for difficography. Now, what are the different operative procedures for rectal prolapse? More than 50 types of repairs have been documented, but most of them are of historical interest only. The general approaches include either abdominal or perineal. In abdominal, you have anterior resection with or without rectopexy, that is, the sigmoid is being resected and the rectopexy is done. Or maybe a rectopexy alone, or sometimes a synthetic mesh is affixed around the rectum and is attached to the presacral fascia. Whereas in perineal, you have the anal encirclement, like what is called the Thiersch-Wiring, the mucosal resection called the Delorme's operation, or the Altimer's operation, or the perineal proctosigmoidectomy. So these are the perineal procedures. Abdominal approaches. All of the abdominal operations for prolapse can be performed either open or laparoscopically. So the resection rectopexy that is, the redundant sigmoid colon is excised and the anastomosis is maintained. That is rectopexy. This is proposed by Friedman and Goldberg, where the recurrence rate is very low, about 2 to 5%. So this is how it is done. You mobilize the rectum, the redundant sigmoid colon is resected, and the anastomosis is done between the rectum and the colon. That is the rectopexy. That is resection rectopexy by Friedman and Goldberg. Whereas in Ripstein's repair, you place a prosthetic mesh around the mobilized rectum where it is attached to the presacral fascia below the sacral promontory. So a mesh is kept around the rectum which is being mobilized and is fixed to the presacral fascia below the sacral promontory. Or sometimes a rectopexy alone is done. When you approach perineally, you have something called the perineal proctosigmoidectomy or the Altimer's procedure. So the approach is perineally. So here what is being done is the prolapsed rectum and the sigmoid is resected through the perineum, and the anastomosis is done between the rectum and the colon with the help of a circular stapler. That is Altimer's operation. Whereas in Delaunay's operation, you do a mucosal proctectomy. That is, the mucosa of the rectum, the sleeve of the mucosa of the rectum is resected up to 15 centimeters from the anal verge. So you make a circumferential incision over the prolapse through the mucosa, and the sleeve of mucosa is resected up to 15 centimeters from the anal verge. Then you leave behind a circular piece of mucosa at the verge and you plicate the muscularis. As you can see from this picture, you plicate the muscularis so that it is being approximated. So the anastomosis of the proximal and distal resected margins of the mucosa just proximal to the dendrite line. So it is being approximated. Or you can do a Thier's operation or anal encirclement. That is, a circumferential stitch is being taken in the submucosal plane round the clock position. Maybe you start from 3 o'clock, go to 6 o'clock, then to 9 o'clock, then to 12 o'clock, then come to 3 o'clock. So that completes one's clock, and it is being tightened to prevent the prolapse. That is called Thier's wiring, anal encirclement. So that comes to the end of the surgical procedures. So today I hope you have learnt about what is rectal prolapse, what is the incidence of rectal prolapse, in which age group it is commonly seen, what are the causes for rectal prolapse in children, in infants, in women, how do you tackle this prolapse in children and infants, how will you tackle this prolapse in adults, what are the anatomy and pathophysiological factors, anatomical and pathophysiological factors behind the occurrence of rectal prolapse, and the different approaches, both abdominal as well as perineal approaches, and various procedures for the treatment of prolapse rectum. Thank you.